incompatibility. As we know, ABO incompatibility leads to the severe hemolytic disorder of the fetus called hydrops fetalis. The Rh factor has five antigens: D antigen, capital C antigen, small c antigen, capital E antigen, and small e antigen. The D antigen is mainly the predominant antigen, and on the basis of D antigen, we decide whether the blood group is positive or negative. If the father is homozygous for D antigen, then the chances of fetus to be positive are 100%, and if the father is heterozygous for the D antigen, then the chances of fetus to be positive are 50%. Then at the there are many instances when the maternal blood comes in contact with the fetal blood, for example at the time of delivery, abortion, abruption, at the time of molar pregnancy, or any injury to the abdomen, or during amniocentesis or chorionic villi sampling. Therefore, when the negative blood of mother is exposed to positive blood of the fetus, then the mother will start making antibodies against the D antigen, and in the next pregnancy, if the fetus is again positive, then the antibodies will enter the fetus via placenta and leads to the hemolysis of the fetal RBCs. And due to this, fetus will develop anemia, jaundice, raised bilirubin levels, and due to increase in the oncotic pressure, the fetus will develop third spacing of the fluids, leading to pleural effusion, pericardial effusion, ascites, and edema, called hydrops fetalis. And to compensate hemolysis, the bone marrow of fetus will form many new RBCs, therefore also called as erythroblastosis fetalis. And the mortality is 20 to 30%. Therefore, to manage this, we give antibodies to D antigen to the female after delivery, and the safe period is within 72 hours of delivery. We give 300 micrograms of anti-D to the female, and the dose basically the dose is calculated on the basis of Klein-Hover Batke test, and from this test we calculate the percentage of contamination of maternal blood from the fetal blood, and the dose is basically depends upon the fetal maternal hemorrhage, and fetal maternal hemorrhage is equal to percentage of contamination into maternal blood volume, which is 100 ml per kg at term. um, we have many other non-immune hydrops cases, and the causes here are cardiac causes like cardiac block, renal causes like autosomal dominant polycystic kidney disease. We have genitourinary causes. We have gastrointestinal causes, infections like parvovirus B19, then thalassemias. Therefore, and also the inadequate anti-D given to the female after delivery. Therefore, it is better to calculate the amount of anti-D required before we administer the anti-D. Nowadays, whenever the female visit to a hospital for the first time, and if the female is Rh negative, we perform indirect comb test during the first visit, and if it comes out to be negative, then we perform the next ICT test after 20 weeks, then repeat every 4 weeks, and if the test comes out to be negative till 38 weeks, then at the time of delivery we give anti-D to the female. And if the patient is Rh negative, and the ICT is negative up to 24 weeks, and it comes out to be positive at 28 weeks, or 24 weeks or 28 weeks, then initially we check the amount of antibodies she is making. Therefore, we perform dilution test, and if the dilution is like 1:2, then the antibodies amount is lesser, and we the safe is up to 1:16 dilution. And then we perform the ICT every week. And imagine if the amount ICT is positive and it is 1:1024 dilutions, then it means that huge number of antibodies are made. And then we find out the hemolysis which is going on in the fetus. Therefore, we perform amniocentesis, then we perform spectrometric analysis, and if the requirement if there is a therefore we check whether there is a need to take action or not, and if required then we go for intrauterine transfusion. Also, to prevent the need of intrauterine transfusion in the third trimester, we give NTD after 28 weeks if the ICT is positive, and the dose given is 300 micrograms. And as it works for 6 weeks, therefore we repeat the dose at 34 weeks and then at the time of delivery.